Welcome to Podium Perspectives, powered by Vaniam Group.
Welcome to Podium Perspectives, Advances in the Treatment of Genitourinary Cancers, FASCO and Rana highlights, a new podcast that shares up-to-date insights across oncology and rare disease. I'm Dr. Petros Grivas. I'm a professor at the University of Washington and Fairfax Cancer Center here in Seattle, and I'm so excited and thrilled to participate in this series with my great friend and colleague, an awesome contributor in the landscape change in GU oncology and global leader, Dr. Rana McKay from UC San Diego. Rana, welcome.
Oh my goodness, Petros, thank you so much for the kind introduction. It's really great to be here with you all. In today's episode, Vaniam Group has brought us together to really discuss all of the highlights from GU ASCO, which just happened, and gosh, so many amazing data getting presented. It's like hard to keep up. So totally excited to dive in.
Thank you, Rana. And needless to say, you're an amazing faculty. You're a leader. You're a mentor. GU Cancers program at UC San Diego with major contributions. And, it's amazing to see the data from ASCO GU. And I know we're sitting together there watching some of those presentations. And I'll start us off discussing a little bit about bladder cancer. And I would love your opinion too. I was really, excited to see data from Keynote B15 trial that our dear friend and colleague, Dr. Matt Galsky, presented. And the data from Keynote B15, just to orient the audience briefly, this is a phase 3 trial randomizing patients to enfortumab vedotin plus pembrolizumab, the new very promising combination that has shown overall survival and PFS benefit in metastatic disease frontline with the EV302 trial. So EV-Pembro was compared to neoadjuvant Gemcis, and the EV-Pembro was given in a perioperative fashion, both neoadjuvant and adjuvant before and after radical cystectomy and lymph node dissection. That trial, it of course, applies to cisplatin-eligible patients with localized muscle-invasive bladder cancer, and the predominant histology had to be urothelial conventional histology carcinoma. EV-Pembro perioperatively, again, neoadjuvant and adjuvant, significantly prolonged event-free survival and overall survival, and resulted in a very promising, much higher pathological complete response rate, reaching 56% in all comers in the intent to treat population, which is much higher than what we have seen with Gemcis in this trial and also historically. We're awaiting for regulatory review about EV-Pembro. It's already approved for cisplatin ineligible patients in this setting, perioperatively based on the Keynote 905 trial, but we're waiting also for the expansion of that approval based on Keynote B15, based on the ASCO GU data. Of course, toxicity is very important to review and comment. I would say that EV-Pembro requires close attention. There are multiple side effects that can happen, immune-related with pembrolizumab, and of course, enfortumab vedotin-related, peripheral neuropathy, skin rash, pruritus, hyperglycemia, anorexia, weight loss, fatigue, loose stool, nausea, taste changes, to name a few. Cytopenias are much less common with this regimen. And of course, the other big question, Rena, and I would love your thoughts, is what about the neoadjuvant and adjuvant therapy phase contributions? Do we need both? I tend to go with trial design for now and try to do both if I can, but based on toxicities, I may potentially adjust. What are your thoughts?
Oh my goodness, this data is just game-changing, right? Like EV-Pembro really across the board. And I think it's going to change the way we treat patients in the perioperative setting. I think this really has supplanted cisplatin-based chemotherapy for a large proportion of individuals. The path CR rates are just so high, and I think it leaves a lot of individuals questioning, okay, what's the utility of the outback treatment post-resection in the adjuvant setting? How can we better optimize that? I believe it's my understanding that patients receive 3 cycles pre and the remainder of the therapy post. So this is 3 cycles of treatment. It's actually not a lot of treatment. Was able to, elicit a pathologic response of, over 55%. So a lot of questions about what to do.
Absolutely. You said it so well, Rana. And, it's amazing to see the field moving so fast forward. As you mentioned, there are many patients who get neoadjuvant EV-pembro. Many of them, most of them, the vast majority went into radical cystectomy. And the reassuring, I think, data point is that the proportion of patients who underwent radical cystectomy and lymph node dissection was very similar in the two groups, showing that EV-pembro is feasible and it does not compromise the ability of patients to undergo curative intent therapy. So I think it's very important to note that. And also the time to surgery seems to be comparable, at least based on the Keynote 905 trial. And of course, the big questions about the adjuvant therapy phase contributions. About 2/3 of the patients went on and received the adjuvant EV-pembro. And in the consort diagram, we saw the reasons why people may not have proceeded with that therapy portion. And your amazing colleague and mentee, Dr. Tyler Stewart, did a great job in that discussion, Rana.
I know, it's amazing. A lot of it's really an exciting time in bladder cancer. I think patients are living longer, they're living better, and hopefully with this therapy, we're actually curing more people from ever developing metastatic disease. And it's going to be really exciting to see the long-term follow-up from the trial.
Absolutely, absolutely. And I think the last quick comment I would say, we still wait, of course, for the manuscript, but it's very hard to achieve both EFS and OS benefit in the perioperative trial in muscle-invasive bladder cancer. And I think the Keynote B15 in cisplatin-eligible patients comes to complement the data from Keynote 905 trial that we saw from Dr. Chris Wulstecki at ESMO 2025 in Berlin, and that now is published at the New England Journal of Medicine. Very briefly, Keynote 905 is EV-pembro, same combination perioperatively before and after radical cystectomy lymph node dissection versus no perioperative therapy in cisplatin-ineligible patients. Again, that is published at the New England Journal of Medicine and led to the FDA approval of EV-pembro as perioperative treatment in cisplatin-ineligible patients. There are some nuances in terms of the number of cycles neoadjuvantly, for example. There were 3 cycles given neoadjuvantly in Keynote 905 cisplatin-ineligible patients, 4 cycles in Keynote B15 cisplatin-eligible patients, mostly for logistical reasons to try to match up the GEM-CIS in the Keynote B15 trial. But overall, I think the data look very strong right now, as you said, and we look forward for the expansion of the label in muscle-invasive in cisplatin-eligible patients. And moving along now, it's so much to talk about, of course, in bladder cancer. Of course, there are many other data sets, posters, presentations, a RETAIN 2 trial by Dr. Gatalia, and a great discussion by Dr. Jonathan Wright, my colleague here. We saw data from Dr. Belmont about IMvigor 011 trial, Professor Powell's about dissident vedotin data. So a lot to cover in bladder cancer. We don't have the time to dive in today, but I know hopefully we'll have more time in future a podcast, Rana. It's really amazing to see the field moving forward. Of course, in the other quick thing before we go to prostate, what's your thoughts about ctDNA in the adjuvant setting? Are you incorporating ctDNA testing based on the IMvigor 011 trial? Are you extrapolating to perioperative neoadjuvant immunotherapy trials, or you keep it only in a niche of patients?
Very good question. I think many of us are ordering it as a data point just to understand prognosis, because it is informative in the discussion around prognosis. But whether it's actually being used, especially now with the EV-pembro data, whether it's actually being used to guide the type of therapy that somebody gets is still to be determined. The modern trial is going to be looking at therapy escalation, de-escalation strategies for patients that are positive or negative. And I think, hopefully there'll be additional insights from that. But I think it's an incredibly useful tool, but I think we need better prospective data now aligned with the current standard of care. The standard of care keeps changing in bladder at every meeting. You can't keep up with it.
Totally agree. And very, very briefly for the audience, IMvigor 011 trial was designed to confirm the hypothesis of IMvigor 010. This was a population of patients who had radical cystectomy, and they were tested by the Signatera tumor-informed assay. If they were ctDNA positive, they were randomized to atezolizumab anti-PD-L1 versus placebo, and that randomized trial showed significant benefit, disease-free survival and overall survival benefit with atezolizumab versus placebo, and atezolizumab reduced ctDNA levels, increased the clearance in many patients. The big question is whether this survival benefit in those immunotherapy naive patients, how do we extrapolate that in patients who had received already immunotherapy in the neoadjuvant setting? So many questions are still pending, but definitely very important trial in Vigor-011. And to close the bladder cancer session, quick comment, the disitamab vedotin anti-HER2 antibody drug conjugate, we saw data by Professor Powell's looking at high response rates in HER2 high and even HER2 lower level of expression in metastatic urothelial carcinoma with this anti-HER2 antibody drug conjugates, having the same payload with enfortumab vedotin, the MMAE. Rana, do you see a future with DV, disitamab vedotin, after EV, or do you think it may be hard?
No, I absolutely do. I mean, I think we need to, I think for me, HER2 is a actionable target in urothelial cancer, and it needs to be leveraged to improve outcomes for patients. The biggest question is how are you going to sequence this within the existing landscape? I think the frontline study is challenging because the bar is incredibly high with EV Pembro. So how do you integrate? Is it something that you're going to do frontline, or is it something that you're going to do post exposure to EV Pem, and what's going to be the activity in a tumor that's been exposed to EV? So I think it's definitely here to stay. It's just a matter of how to integrate.
Very well said, Rana, as always. And I'll let you comment and discuss the exciting data in renal cell carcinoma. It's so much going on, and you have been leading the field.
You know, it was really exciting to see two large phase 3 trials read out in RCC that are likely going to be practice changing. So first, we'll start with LIGHTSPARK-022. This builds on the successes of KEYNOTE-564. KEYNOTE-564 was a study that was conducted for patients that had a high risk of relapse post-nephrectomy, giving adjuvant pembrolizumab, and looking at disease-free survival and overall survival. It's the first therapy that's ever demonstrated an improvement in overall survival, from thousands of different patients that have enrolled on multiple adjuvant studies in the cytokine era, the TKI era, the first study to actually demonstrate an improvement in OS. And now this has become a standard of care. And so LIGHTSPARK-022 basically looked at the addition of belzutifan to the backbone of pembrolizumab compared to pembrolizumab for patients with high-risk clear cell RCC post-nephrectomy. And, here the study was positive. It met its primary endpoint, resulting in a statistically significant improvement in disease-free survival of combination therapy versus pembrolizumab. And this is, against a very active control arm that improves overall survival. I think the toxicity that was observed was that akin to what we would expect with belzutifan, a HIF-2 alpha inhibitor, which can cause anemia, in some cases hypoxia, and also pembrolizumab as a checkpoint inhibitor. So I think there's many questions that remain unanswered regarding who, like who should be getting escalated therapy. So actually, the first question is who should be getting adjuvant therapy, and then answering of the people that get adjuvant therapy, who should be escalated? Like, how should I administer the therapy? Just Pembro alone or Pembro with Bel? So I think there's going to need to be additional follow-up on OS. The OS data are still quite immature, but I think that this data are really definitely shaking the field. It's not like the TKI era where we tested a bunch of TKIs that were all negative. I think the tolerance to a HIF-2 alpha inhibitor differs from that of a TKI. And I think to see a really profound DFS improvement in the context of this robust study is really great. So I'd love to understand your perspectives around, therapy escalation in the adjuvant setting. There's probably a subset that are going to be cured with surgery alone. There's probably a subset that are going to be destined to relapse regardless of what you do. But how do you leverage that group that's in the middle that you could potentially cure with an adjuvant strategy?
That's a great summary. I agree with you. I think it comes down to refinement of patient selection, and we're getting there. We need more work with biomarkers. I know in the field of renal cell carcinoma, a lot of work with KIM-1 levels, circulating tumor DNA, maybe coming with, better assays with better performance characteristics. I think, I remember, when we talk about prognostic estimates and prognostic nomograms, can this help us calculate the risk of recurrence and then help inform the dialogue? Since we lack predictive biomarkers for now, maybe KIM-1 may be validated in that regard. So I think it comes down to patient selection. I think disease-free survival is a meaningful endpoint. And I say that because, patient advocates say that, and I know you and me talk to many advocacy groups. And also because if we think about overall survival, which is ideal and the gold standard and preferred to see, of course, but sometimes can be confounded by access subsequent salvage therapies, effectiveness of those salvage therapies, and many other factors. So, comorbidities and stuff. So I think OS is the gold standard, but disease-free survival, I think, is a very reasonable, in my humble opinion, acceptable endpoint, but it has to be balanced, to your point, with toxicity and quality of life, patient report outcomes metrics. It comes down to individual patient decision-making, right? Pros and cons. For now, pembrolizumab, based on Keynote 564, has OS benefit, is FDA approved. Have to see what will happen with belzutifan addition in that context. And if it gets approved, I think individual decision-making, balancing toxicity and benefit, cost considerations, of course, is another factor.
No, absolutely. I think all well said around, what's the, benefit versus the risk. And, for any given patient, that scale of what's my risk tolerance for what I'm going to gain is different. And you could have 10 patients in front of you and they're all going to make a slightly different decision, even though their risk may be the same, given, patients have, their different states, different things that they may value, and different social environments and networks. And so I think there's a lot of perspective around risk in that regard, So super exciting to also have another phase 3 reported out at the same meeting, 2 back-to-back phase 3 oral presentations, super exciting. So the second large study that read out that is, practice changing, even I think tomorrow, is like LightSpark 011. This was a phase 3 of belzutifan lenvatinib versus cabozantinib post PD-1, PD-L1 exposure for people with advanced clear cell RCC. So this was a study that was looking at therapy escalation in the second line setting post modern day IO treatments. I think the sequencing of treatments in the context of advanced disease has really been an open field, because a lot of the old studies of second line therapies were not done in the modern era, where patients were receiving IO combination strategies frontline. And we gleaned some insights from CONTACT-3, looking at the control arm of cabozantinib in that study, and other, TiNivo, for example, TiNivo-2, that looked at tivozanib, nivolumab, and looking at the activity of tivozanib in patients that may have received more modern day frontline IO. But there hasn't necessarily been a specific study designed at what's the appropriate sequence or escalation strategy in later line. And so this was really great to see this data. It was a positive trial demonstrating an improvement in PFS of the combination compared to cabozantinib, with also an improved objective response rate. I think the OS data are still, immature, though there is a numerical difference in OS, that's longer with the combo. What was really striking to me about this data that I think was a little bit unexpected was the duration of response. And so there's a subset of patients, probably about a third of patients, like when you look at the landmark PFS, about a third of patients were alive and progression-free at 2 years, which is really a unique thing when you're talking about a second-line therapy strategy. So some of these responses, I think, tended to be quite durable. So I think it's going to be really important to understand how that evolves, and I think as we think about mechanism of action of belzutifan as a HIF2 targeted agent that very specifically targets HIF-2 alpha, I think its positioning probably earlier or on in less heterogeneous disease that's more addicted to the VEGF-HIF pathway is probably going to be informative and impressive. I think we saw that in 022 and now with 011. So I love your impressions. If you have a patient before you now and progressing on frontline, is this something that you would consider, or how do you strategize?
I think your points are well taken, and it's hard to get positive phase 3 trials, right? And especially in the post-immunotherapy setting in metastatic renal cell carcinoma, we have seen previous trials utilizing a rechallenge of immunotherapy strategy that were not positive, and the IO rechallenge remains a question in other cancer types. But I think this trial, based on the results you quoted, the response rate, the signal for OS, even if it did not reach significance, it's still, I think, a numerical difference there. There's a trend, and also, putting together the totality of the data in this setting, I think belzutifan and lenvatinib represents a very reasonable option. And of course, again, comes down to individual discussion with the patients, medical comorbidities, particular, factors in the individual patients. But I think it's a very compelling, I would say, option for patients. And we need to optimize the therapy sequence. We do not know the optimal sequence, but usually we try to use the best, treatments as early as we can, to your point, and maybe we can learn more from biomarker analysis. But I agree with your comments about reviewing the data. Of course, if that it's approved, I think it's a very viable option to at least discuss, and I'm sure it's going to be used for a proportion of patients.
Yeah, super exciting. All right.
Absolutely.
So that's kidney. I think there's going to be a lot to come over the next couple of meetings as these data get further dissected with subsequent subgroup analysis. So kind of taking us home here is prostate. And, I think that we saw top line data from piece 3, the final OS. Maybe Petros, you could walk us through the piece 3 data that were presented.
For sure. I'll try to keep it brief because time runs fast. Piece 3 randomized phase 3 trial looking at the combination of radium-223 plus enzalutamide versus enzalutamide alone in patients with metastatic castration-resistant prostate cancer with bone metastasis. 446 patients with mild symptoms or no symptoms were randomized, and there were specific selection criteria, of course, because of the use of radium in this population, based on the older data from the Alsimca trial that led to the radium-223 FDA approval back in the day. This trial, as you mentioned, was positive for overall survival. It's interesting because if we look at the Kaplan-Meier curves, there is some crossing of the curves. Looking at that statistically, it may violate the proportional hazards model assumption. So that created a lot of discussion. I think Dr. Evan, you did a great job in his discussion at the meeting that we attended together. Overall, I think one major point is that the vast majority of those patients did not receive prior ARPI, anti-androgen axis inhibitor, abiraterone or enzalutamide or APA or DARO. So these were technically vast majority, ARPI naive patients, and this could be an option for patients, in the first line setting of metastatic CRPC. I think overall, it reminds us of the value of radium-223, and it's an active drug. It's probably one of the few agents with 2 positive phase 3 trials. And I think it's important to remember that. So in selected patients who, for whatever reason, did not receive prior RPI, I think radium-223 plus enzalutamide looks a very reasonable option. And the question is, how do you extrapolate in those with prior RPI exposure? I think there could be a role in selected patients. I would love your thoughts, Rana.
No, totally. I think the trial didn't specifically, obviously, answer that question. I think that's the big question in the field now as the frontline space is changing. But I think this was an incredibly active regimen. And when we look at the long-term overall survival, pretty impressive to see an overall survival of 38 months, I think, in the combination. So it's going to be interesting to see how people end up using radium. In my practice, I want to ensure patients have access to every single life-prolonging therapy when they have MCRPC. MCRPC is grossly undertreated. Most 25% of patients never actually see any treatment. And of patients that see frontline, 50% never see second line. And many people don't ever see, subsequent life-prolonging therapy. Most people mainly see a subsequent ARPI as their main life-prolonging therapy in the MCRPC setting. So we've got work to do. So I think this is definitely, hopefully, going to help provide another therapy for individuals that could improve their outcomes. And I think with that, maybe we segue into PSMA addition updates from quality of life that were presented. The initial data from PSMA addition presented at ESMO last year. This was a trial that looked at the addition of lutetium PSMA 617 to the backbone of ADT ARPI for patients with PSMA positive hormone-sensitive, metastatic hormone-sensitive prostate cancer. And here we see the subset analysis with regards to the health-related quality of life. And while patients had escalated therapy with a different triplet regimen, if you will, ADT, ARPI, and a radiopharmaceutical, we didn't see any major signal with regards to compromised quality of life or pain control in this context. Time to symptomatic skeletal-related event was not reached in either arm. So, I think there's a lot of questions that remain around how to integrate lutetium into the frontline setting, in the hormone-sensitive setting. How much lutetium? Should people get all 6 doses? What's the right patient population? So I think there's a lot of questions that remain to be had about its integration. So I don't know if you have thoughts on the PSMA addition and the integration of upfront radiopharmaceutical therapy.
Great points, Rana. I think we are struggling to optimize, therapy duration, especially in this setting, right? Do you need all those 6 doses, right? If you get a great response and you saturate the targets, let's say, do you need to go beyond 2 or 3 cycles? That's an open question. I think we need some potential de-escalation trials, and I know you're working, in interesting trial designs, through alliance and cooperative groups, because it's amazing to see trials that met the primary endpoint, and that's important to note and acknowledge in PSMA addition. At the same time, I think questions remain about the optimal therapy duration, utilization, patient selection, adaptation, right, using PSMA PET, for example, during treatment, and I hope that we can get those answers potentially through cooperative group trials. I think it's great to have options for the patients. We saw, Capitello 281 trial, PSMA addition, amplitude. We're starting to create buckets and categories based on biomarkers. We need to sort out, logistics, patient selection, optimal therapy duration, toxicity management. So we'll see what happens with regulatory review, but I enjoy your comments.
Now, super exciting time to be caring for patients with GU cancers. A lot of exciting therapies and biomarkers and diagnostics coming down the pike. So it's been really great, having you all listen to this episode of Podium Perspectives. Petros, why don't you take us away?
Rana, such a great pleasure to talk to you. I get energized and inspired every time since 2013 when we first met at the AACR ASCO Vail workshop, and we keep working together. It's amazing to discuss. I want to thank the audience for attending. Please follow and share to stay current as new data come out rapidly and so quickly. This podcast episode with Dr. McKay and myself is for educational purposes only and cannot be used for medical advice, of course. Please stay tuned, and I hope to see you again next time. Thanks again for the time, and thanks, Rana, for your time too.
Thank you all.
Thanks for joining Podium Perspectives, powered by Vaniam Group. This episode is for educational purposes only and is not medical advice.